Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Hello, everybody. I have no disclosures, start disclaimer, and the outline for what we'll talk about is mostly about cabotegravir-rilpivirine and the updates that we saw there, and then a little bit on the combination of doravirine and islatravir. So as far as the long-acting cabotegravir-rilpivirine updates, I wanted to first start off with a 96-week update about the CARES study, which I discussed last year after the CROI report back, which, as a reminder, was a phase 3b randomized open-label active-controlled non-inferiority study in sub-Saharan Africa of individuals who were over 18, on a stable regimen, virally suppressed, and no history of renal failure, no hepatitis B, who were randomized to either oral ART or to cabotegravir-rilpivirine every 8 weeks, plus minus an oral lead-in. What I think was remarkable about this was viral loads were checked every 24 weeks, which is at a frequency less frequent than what we're doing here, and was using or utilizing a public health approach to enrollment, which they didn't go into much detail in the abstracts about what exactly that entailed. But one component of that is that resistance analysis was performed during therapy, and then proviral DNA was performed for archive resistance on stored PBMCs. So this was a group of individuals who were virally suppressed and then just randomized without having, a baseline genotype and this very rigorous review process, who were then randomized to being on Cabril every 8 weeks and then got their viral loads checked every 6 months or so, if I do my math correctly. So these were the key baseline characteristics of individuals there. Overall, 20% of people had a BMI that was greater than or equal to 30. People had been on their first-line ART regimen for a median of 8 years, and so pretty long time being on their regimen. 74% of people were previously exposed to NNRTIs, which I think is of not surprise given the use of TDF, FTC, and efavirenz as a first-line regimen in sub-Saharan Africa for a very long time, until tenofovir, DF, lamivudine, and dolutegravir became first-line. And 92% were on an INSTI-based regimen at screening. So this is the people who are on TLD and then placed on this. This is, again, information that was obtained after the fact, but 55% of people had viral subtype A1. We learned about this at last year's CROI, and I think that it was significant because it meant that we could change how we feel about using cabotegravir-rilpivirine in people who have an A1 subtype virus. And now, after the CARES study, we have adjusted so that we are okay with using Cabril in A1, and it's really just the A6 subtype that gives us pause. And 7% of people had rilpivirine resistance mutations, 10% of people had CAB resistance mutations, and if I recall, there were relatively low percentages of people who had intermediate level resistance. And the 96-week results look very similar to the 48-week results, almost exactly the same to the decimal point. And the sort of finding was that long-acting Cabril was non-inferior in virologic efficacy as compared to oral standard of care. 77% of people had an injection site reaction very similar to the 48-week data. Over 99% of people on long-acting Cabril preferred injectable to daily oral therapy. 81% of participants received their injections within a 7-day target window, which I think is significant because even using this public health approach, that most people came in within that 7-day period. So that's a highly adherent group. And there were 4 cases of virologic failure, whereas at the 48-week data point, there were 2 cases of virologic failure. At 96 weeks, there were 4 cases. So I'm going to go into those details, but the sort of big takeaway from this slide is, wow, this worked really well, was non-inferior even at 96 weeks. And here's some information about those 4 virologic failures. This is directly from their abstract, and you can see here the grayed out is what was present in the 48-week data. And here are participants 3 and 4, the 2 subsequent virologic failures. I think what I would like to do is draw your attention to, first, the baseline mutations that were present, which is the lower chunk of this slide. And so here you can see that some of them had what looks like pretty high level NNRTI resistance, especially with the E138s. This person had a L74M at baseline, and then here we don't have any other INSTI resistance. And then when these individuals did subsequently develop virologic failure and accrual of resistance-associated mutations, they failed with high-level NNRTI resistance and high-level cabotegravir resistance. That being said, although this is a kind of downer slide, the fact of the matter is this is still a relatively low percentage of virologic failures, only 1.6%. So in summary, regarding CARES, at week 96, long-acting cabril, every 8 weeks administered in a public health setting in sub-Saharan Africa, was non-inferior in virologic efficacy to oral standard of care, had a good safety profile, and was well tolerated. We saw that there were 4 cases of virologic failure that occurred with emergence of INSTI resistance and NNRTI resistance, and this remains an important contribution, not only regarding broad implementation in sub-Saharan Africa using a public health approach, but also in individuals with high exposure to NNRTIs and pretreatment resistance, perhaps, and different subtypes of HIV-1. And so I know I've talked about this with Brian, at least, that I think that the CARES study takes some weight off of my shoulders, really, with regards to, I'm like, oh gosh, we need to screen people and be really vigilant and make sure that people are coming in. I still feel that way. But if someone doesn't come in the back of my mind, I'm like, it's okay. We'll get a viral load later. I try at least to tell myself, because as many people know, I'm kind of a high anxiety person. And so this relieves some of that anxiety. And it was really nice to see that it can be done and implemented on a large scale so well, obviously with lots of logistical support. So this was important, and I just wanted to share the 96-week data. The rest of the cabril stuff, we're just going to go through kind of quickly. So what are some key highlights from the observational data? It's always really nice to see real-world experiences, and so I'm going to share some results from the OPERA cohort in general, viral suppression in women in that cohort, and then viral suppression in the TRIO cohort. And so in the first group, in the OPERA cohort of about 2,700 people with HIV who started cabril, 83% remained on it at the end of the study period. With a median follow-up of 11 months, 95% had virologic suppression, which is great. And then after, again, their medians are different based on sort of timing, but 21 people, or again, 1% had confirmed virologic failure. In the cohort specifically amongst women, 532 had started cabril, 78% were on cabril at the end of the study period. At the end of their median follow-up of 12 months, 94% had viral suppression and 1.3% had confirmed virologic failure. And then last, similarly, in the TRIO cohort of 1,200 people who are virally suppressed, 79% stayed on it at the end of the study period. Median follow-up of 12 months, 95% had viral suppression and 1.6% had confirmed virologic failure. And I have included the people who had failed and what resistance they accrued. So takeaways from this slide is it appears, and I will sort of touch on this a little bit later, that of these cohorts, most people stayed on the injectable for the study period. That maybe about 15 to 20% actually stopped. And then of those people that stayed on, there was excellent virologic suppression, high 90s, and our confirmed virologic rates were in the 1 to 1.5% range. So that's all very consistent with what we've seen. What about people who were starting cabril with viremia? Kind of different cohort than the one I just showed you. So there were 2 abstracts that were shared. These are both posters. At Ward 86, 370 people with HIV who are on cabril. Of that cohort, 35% started while viremic, and 98% achieved and maintained virologic suppression at 48 weeks. And there was no statistically significant difference in viral suppression between those who were virally suppressed going into it or those who were viremic going into it. However, I'd like to acknowledge that I think it takes a lot more work to keep those individuals who start viremic sort of engaged in care. At least that's from our personal experience here. And so I just want to acknowledge that. The other one was from the Ponce Clinic at Grady Hospital in Atlanta. 361 people with HIV on cabril in their entire clinic. 22% started while viremic. 92% of those achieved viral suppression. And of those 6 who did not achieve viral suppression, 2 had virologic failure with NNRTI and INSTI-RAMs, 2 had persistent low-level viremia, and 2 had sort of virologic failure, but without the accrual of resistance mutations. So again, very high virologic suppression rates, even in people who are starting viremic. What do we know about pregnancy? Very little about its use in pregnancy. And there was this abstract of a multi-center retrospective chart review of pregnant women prescribed long-acting cabril. 23 received it during pregnancy. 11 were getting it once monthly. 12 were getting it every 2 months. 73% initiated it prior to pregnancy and sort of stayed on it. 27% switched to it during pregnancy. And then they looked at an outcome of viral suppression at delivery. And among those who had stayed on cabril during their pregnancy, 20 out of 21 had a viral load that was less than 200. One person had a viral load greater than 1,000. And 81% of newborns received AZT only post-delivery, and there were no cases of vertical transmission. This was a nice poster to have, and I think their outcome or their sort of conclusion, and mine as well, is we need more data, but this is helpful, especially for those of us who have been in scenarios where we have to use this in pregnancy. And then the sort of last thing I'd like to end with regards to cabril is, why do people stop it? So now it's been FDA approved since 2021. We have enough information now to see who's stopping it, how many people, and why. And so we actually have data again from Ward 86 and from the Ponce Clinic. This poster was of, at this time, 437 people with HIV starting cabril. Median time on treatment was 553 days, which when I did my math, was about 1.5 years. 16% actually stopped treatment. And among those who started virally suppressed, the most common reason for discontinuation was pain. And then among those who started viremic, lateness of injections and virologic failure drove discontinuation. And I've included a screenshot of their table about the reasons why it was stopped. And then, I apologize. I misspoke. It wasn't the Ponce Clinic. It was actually the Owen Clinic. Getting all my clinics confused. And this was in San Diego, 465 people with HIV starting cabril. Median time on treatment was 164 days. So like maybe half of a year, not a whole lot of time. But again, kind of similarly, 20% of people stopped their cabril. One person actually developed an NRTI resistance during this PK tail because baseline they were virally suppressed, had no resistance. After 2 injections, they were lost to follow-up, which, as we know in real life, oftentimes can happen. They showed back up again after 9 months, and at that time had a viral load of 36,000, and they checked a genotype at that time. They had a Y181C. Interestingly, concurrently, they did a proviral DNA that showed much more resistance. But I think that this is, for me, was interesting to see, like, what happens actually if you lose someone to follow up, and there is that tail, and this is what could happen. Someone could develop resistance even though they're not taking anything else. And then of this UCSD cohort, 20% of people who stopped cabril, it looks like, again, about 30% of them were stopped due to injection site reactions, 12% due to a different side effect, 11% due to insurance challenges, and there were some other ones as well, in addition to difficulty coming in, logistical issues. So I thought that these 2 posters were helpful just to see kind of what's going on in real life, how many people are stopping. And I think it's also important for us to remember, and especially when it comes to our patients with any medication, it's not a forever medication, right? It doesn't have to be. It can be, but it doesn't have to be. And so I don't think we need to think of cabril-rilpivirine as a end-all destination. It might be something that somebody wants to use for some period of time and then not. So that was the hopefully quick run through of all the cabril-rilpivirine updates. And last, I wanted to finish up with the combination therapy of doravirine and islatravir. So as a reminder, islatravir is a NRTTI, a nucleoside reverse transcriptase translocation inhibitor. We might recall a couple of years ago, we saw issues with islatravir where the higher doses, especially specifically at 0.75 milligrams, led to declines in CD4 T cell and total lymphocyte counts. And this was because, at least in my reading, that islatravir really concentrates within these cells and leads to apoptosis and then leads to these low numbers. So this was kind of paused by the FDA, and then they did subsequent studies and figured out that, okay, we think 0.25 milligrams of islatravir is safe. And so what they're doing now is just repeating those initial studies, but with a lower dose of islatravir. And in this specific case, combined as a sort of single tablet regimen with doravirine. And so There are two studies that I was going to share. Both of these were oral abstracts. The first oral abstract was about 500 people who were virally suppressed on BF-TAF, randomized 2-to-1 to the doravirine islatravir once daily versus continuing their BF-TAF. And at 48 weeks, viral suppression was high, and they found that doravirine and islatravir was non-inferior. And then here I went into some detail that 2 people in that arm had a viral load greater than 200, but there was no treatment emergent resistance. And then another 2 people on islatravir doravirine, 1 on BF-TAF, actually stopped the medication due to decreases in their T cells or their total lymphocyte counts. And then the other study was 550 people virally suppressed on baseline ART, randomized 2-to-1 to doravirine and islatravir versus continuing whatever baseline ART they were on. And again, viral suppression was high, and doravirine and islatravir was non-inferior at 48 weeks. 5 people in the islatravir doravirine arm had virologic failure, but there was no treatment emergent resistance. So when hearing about these results, I think I was like, great, cool, lower dose of islatravir, 0.25 milligrams, seems like better. What is the scenario in which I'm going to be using this whenever it does eventually become FDA approved? And I think what was significant, and even what the investigators shared in their conclusions, was that this is the first time that there's a 2-drug regimen that doesn't use an integrase inhibitor that showed efficacy and non-inferiority to an integrase-containing regimen. So perhaps in the future, if someone is considering a NRTI-sparing regimen, though this is using an NRTTI, or wants to use a 2-drug regimen and not use an integrase inhibitor, this is a potential option. So my conclusions, again, week 96 CARES data demonstrated that Cabril Q8 weeks was non-inferior to oral standard of care in sub-Saharan Africa. In observational cohorts of individuals on Cabril, viral suppression remains high in the mid to high 90s, including in people starting viremic. Long-acting Cabril may be a viable option in pregnancy, but more studies are needed. In clinics with large numbers on Cabril, approximately 15 to 20% of people with HIV have discontinued injections, mostly due to pain and injection site reactions. This was actually higher than in the registrational studies, and so just a little bit more real-world data. And then last, doravirine islatravir appears efficacious and safe at this dose of 100 and 0.25 milligrams in phase 3 trials.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.